Very good morning, friends. So please do confirm if I am both visible and audible. Please write down in the chat section if I am visible and audible. So a very good afternoon for all of you. So today in this channel of Unacademy NEET PG, where clinical cases are going to be discussed, we will deal with papulosquamous disorders. Okay, but before that, brief about myself. I am Dr. Maddineni Srinivas, your dermatology educator on Unacademy. I have done my MBBS from Siddhartha Medical College and diploma from JSS Mysore and second DNB from Hindu Rao Hospital, Delhi. And this is my Unacademy profile. You can follow my profile to get all the latest video updates whichever I am posting on the Unacademy platform, and these classes are absolutely free for all of you to watch. These are called as special classes. So if you are unaware, you can watch these sessions without any subscription, and you can also download the PDFs which will be explained in the sessions. So this was a FMGE course which was exclusively for Plus subscribers, and these were all the days when the topics were discussed. And if you are unaware, few points about this Unacademy by the time which students will join. So this is the largest online teaching platform where you can get classes on YouTube, few classes on special classes on Unacademy learning app. So to view all those classes, you should just download this Unacademy learning app, which is India's largest online teaching platform, and you can listen to the classes and also download the PDFs for your future references. And what will be the advantage of this Plus subscription? With the help of this, you can attend daily live classes, and there are courses which are structured according to the needs of the students and also according to the examinations which are nearby. And there will be live tests and quizzes which will be on a daily basis or weekly basis and also on a monthly basis. There will be unlimited access to all the videos of all the educators, unlike other apps where there is a restriction for few number of hours. So here the access will be unlimited. And if you wish to take the subscription of just the Plus course, that is just the Unacademy, you can use the referral code DRMST for a period of 1 month, 3 months, 6 months and 12 months and 18 months. So these are all the durations for which you can take the subscription, and the subscription charges will be reduced by 10% if you use my code DRMST. And now the Unacademy has collaborated with PrepLadder, so we get iconic subscription which has both Unacademy as well as PrepLadder both put together. So here you can watch the videos of Unacademy on live and also attend the PrepLadder offline classes and also access the question bank of PrepLadder, whichever is your interest. So both of them can be accessed with this subscription. Its name is called iconic subscription, and here the subscription will be from minimum of 1 year duration, and here also you can use my referral code DRMST. And also there is one more small announcement that daily at 8 o'clock and 9 o'clock in the night, 20 MCQs are being asked in the Unacademy learning app, which are targeting NEET PG 2021 and NEET PG 2022 respectively. So you can join these and attempt the 20 questions and find out at what point, at what level you are standing when compared to all the other students. So these are the topics which we are going to discuss in today's class: psoriasis vulgaris, gutted psoriasis, pustular psoriasis, lichen planus and pityriasis rubra pilaris. So those who are watching, please do attempt this question and answer whatever you feel is the correct option. That is we should select the incorrect statement among the following. So okay, I will just explain this in brief. So from the question you can say the patient presents with erythematous scaly lesion on the extensor aspect of the elbow and knee. So the question is asking which of the following statements regarding pathophysiology of this disorder is incorrect. So we need to answer the incorrect statement among the following. So from the question, if you have understood that the diagnosis is psoriasis, so your diagnosis is correct. So Dr. MD Ijaz Alam says option C is the answer. Very good. So this is the diagnosis is psoriasis, whereas regarding the pathophysiology, hyperproliferation of the epidermis is seen in psoriasis. This option is correct, and psoriasis is in fact associated with HLA-CW6. This option is also correct, and there will be cytokine released in psoriasis in the skin lesions, and those cytokines are mainly interferon gamma, tumor necrosis factor alpha, and interleukin 17. So option D is also correct. So what is the answer here? So it is option C, which is incorrect. Why? Because there is going to be an elevation, an increase in the Th1 and Th17 helper cells, but not a reduction. So very good, Dr. Ijaz Alam, your answer was correct. So we will see few points. So this is the answer, I have marked it for you. So we will see what are the papulosquamous disorders and what are the characteristics of these in the clinical practice. So these disorders, they are going to have papules and also plaques as the skin lesions. So I hope all of you know what are papules and plaques. So I will just briefly tell you. These are the solid raised lesions. So both of these are solid raised lesions. The only difference is in the size. So papules are going to be less than 0.5 centimeters in size, whereas plaques are going to be more than 0.5 centimeters in size. And both of these are going to be surmounted by scales. So scales can be seen. So what is the scales? It is the desquamating stratum corneum. Okay, usually the stratum corneum will get shed off in all the individuals, but it is not visible to the naked eye usually. But in certain disorders, what will happen, like for example in papulosquamous disorder like psoriasis vulgaris. So in psoriasis vulgaris, there is going to be a reduced epidermal transit time. The usual time, which is usually ranging from 42 to 75 days, is going to reduce by 10 times, and only in a period of 4 to 7 days. The stratum basal cells, they do reach stratum corneum and they will be shed off. So in just 4 to 7 days, in contrast to the usual time taken for the stratum basal cells to get themselves converted into stratum corneum, here the cells are getting shed off within a very short duration of time, that is 4 to 7 days. This is called as epidermal transit time. So because of this, there will be very rapid conversion of the stratum basal cells into corneum, and thereby these will appear as scales to the naked eye. And these are the skin lesions where you are able to see papules are present. Papules are present here, and also you are able to see the plaques. So we will see what are all the disorders in which papulosquamous type of lesions can be seen. So if you have seen this is a very good mnemonic with the help of which you can remember all the examples for papulosquamous disorders. So the mnemonic is 10 slips. So T stands for tinea. So even the fungal dermatophytosis, superficial fungal infection, tinea also is going to show papulosquamous type of lesions. Eczema, which is dermatitis, neoplasias like Bowen's disease. So this is the small mnemonic with help of which you can remember. S stands for squamous cell carcinoma, B stands for Bowen's disease, and M stands for mycosis fungoides. And the other letter is S, that is secondary syphilis. Please remember, secondary syphilis will show papulosquamous type of lesions, but not congenital syphilis. This was a MCQ which was asked once. So L stands for lichen planus, and P stands for there are many diseases starting with P and showing papulosquamous type of lesions. So they are psoriasis, parapsoriasis, pityriasis rosea, pityriasis lichenoides chronica, and pityriasis rubra pilar. So all these are examples, and they are very, very important. And S stands for seborrheic dermatitis. So I just want you to note down the very important point, that is both basal cell carcinoma and congenital syphilis, they are not going to show papulosquamous type of lesion. So BCC and congenital syphilis, they will not show any papulosquamous type of lesions. So now moving on to a little bit about the pathogenesis, etiopathogenesis of psoriasis. So here we can see that the first part is going to be triggers which are present in the environment, or it could in a genetically predisposed individuals. These environmental triggers, they are going to provoke the keratinocyte injury, and there will be increased antigen presentation, because of which what will happen, there will be increased production of the pro-inflammatory cytokines, which are interleukin 17, interferon gamma, and tumor necrosis factor alpha. So these will be increased, and because of which there will be activation of the T cells by the myeloid dendritic cells, leading to Th1 and Th17 activation. So these Th1 and Th17 activation will ultimately lead to a furthermore increase in the interferon, tumor necrosis factor alpha, and finally there will be production of interleukin 17 and 22, because of which there is going to be epidermal hyperproliferation and dermal inflammation, which are ultimately triggered. So this is the etiopathogenesis which I have seen. It is basically to be remembered, psoriasis is a papulosquamous disorder which is chronic inflammatory T cell mediated disease. Okay, so this is the crux of whatever I have told you in the previous slide. So if you see what are the triggers, so we have seen in the previous slide that say there are some triggers. So in the environment, it is winter season which can act as a trigger, and also there are certain infectious agents like group A beta hemolytic streptococcus, which can also trigger psoriasis, and a particular type of psoriasis. So I will tell you about this in the few upcoming slides. So there are certain genetically predisposed individuals in which there are HLA-CW6 and B27. So this HLA-CW6 is associated with early onset of psoriasis vulgaris, okay, and HLA-B27 is associated specifically with psoriatic arthritis. And please remember, this psoriatic arthritis, it is important. Why? Because it was asked in this INI-CET. It was asked in this INI-CET, and the question said iritis is seen in. So this was a question, iritis is seen in, and one of the options was psoriatic arthropathy. And yes, in psoriatic arthropathy also we get to see iritis. And also other options were Behçet's disease. Even in Behçet's disease also we get to see iritis, and also ulcerative colitis. So all these options were the answers in the question which was asked in the INI-CET. So this was asked in the INI-CET exam, okay. Yes, and Yeah, now coming to what are the other triggers. So in the drugs, what are the important drugs which can induce psoriasis? They are, you can remember with the small mnemonic, PLABs. Okay, this is the good mnemonic, PLABS, PLABs. So in which we have P, which stands for painkillers, and L stands for lithium, which is a drug used in bipolar disorders, and A stands for anti-malarials like hydroxychloroquine, which is very much in the news due to the COVID situation, and B stands for beta blocker. So these are antihypertensives, and S stands for systemic steroids. So painkillers, P, L, A, B and S, PLAB. So this is a very good mnemonic. So systemic steroids, not just the steroid intake, but it is the withdrawal of the steroids which will provoke the trigger the patient to land up into. There are two possibilities when a patient takes steroids and abruptly stops the steroids. So the patient can either land up into pustular psoriasis, or they can also land up into erythrodermic type of psoriasis. Okay. So these are some of the HLAs and their associations in dermatology. So HLA CW6, it is associated with early onset or juvenile type of psoriasis, and also guttate psoriasis, about which we will see in a minute. And HLA B27, I hope all of you do remember this. HLA B27, it is associated with not only psoriasis but also other conditions, which I think you remembered with help of this very good mnemonic, PAIR. So where P stands for pustular psoriasis, A stands for ankylosing spondylitis and acute anterior uveitis, I stands for inflammatory bowel disease, and R stands for Retter's syndrome. So these are all the conditions associated with HLA B27. So this clinical picture I have already shown you and explained you. So there will be red scaly papules and plaques which can be seen mainly situated on the extensor. So all these lesions are mainly situated over the extensors, but not over the flexors. So this is important in psoriasis vulgaris. Yes, and the lesions are going to be surmounted by micaceous silvery white scales. And the other areas which are important in psoriasis are scalp and also the lumbosacral areas. And unlike what do you think, contrary to the belief that these psoriatic lesions may be extremely itchy, by looking at the lesions clinically, the patient usually will not have much of any symptomatology. So there will not be much of itching. Usually itching is absent in psoriasis patients. So now please try to attempt this question in the chat section, friends. I want all of you to answer it. So among the following, try to choose the correct statement. And also, if you understood what is this particular sign which is being talked about, also do comment what is the name of this sign. So do not bother if the answer is correct or not, just try to attempt the question, that's all. Okay, so Ijaz says it is A. So please read the question. So here the sign which is seen in psoriasis is being asked. So please answer here is, please remember it is punctate bleeding spots. So not C, sorry, not C, it is B. Okay, the answer is B here, punctate bleeding spots from the elongated capillary loops. Okay, B is the answer, and the sign which is being discussed here is Auspitz sign. It is called as Auspitz sign. So you are able to see in the picture there are some bleeding spots which are present here, small bleeding spots, and there is scaling which is seen at the periphery. So in psoriasis there is this very important sign called Auspitz sign, where we'll take a glass slide and we'll try to scrape off the scales and see what we can find at the base. So if you do this test, this test is called grattage test, and slowly the scales will be removed and there will be bulkless membrane which will become visible, and after you remove this membrane also, then we'll get to see this pinpoint bleeding spots. And basically these bleeding spots are visible due to these dilated capillary loops. So these dilated capillary loops are present. These dilated capillary loops are present in the dermal papilla. So when you take a glass slide and do the scraping, these stratum corneum and the superficial parts of the epidermis, so these parts are going to be scraped off, exposing all these blood vessels, because of which the pinpoint bleeding is evident clinically, and this is called as Auspitz sign. And few very important points about the Auspitz sign. Auspitz sign is characteristically seen in psoriasis vulgaris, but please remember, this Auspitz sign is not exclusive for psoriasis vulgaris. Why? Because it is also seen in Darier's disease and also actinic or solar keratosis. Okay, so this Auspitz sign, it is not characteristic of only psoriasis, and also Auspitz sign is not seen in psoriasis. There are other types of psoriasis which are guttate, pustular and erythrodermic psoriasis, and in these three conditions we cannot elicit the Auspitz sign. So please remember, Auspitz sign is seen in psoriasis vulgaris, which is also called as chronic plaque psoriasis, and it is absent in guttate, pustular and also erythrodermic types of psoriasis. And there is one more important phenomenon which can be observed in psoriasis. It is called as Koebner's phenomenon, where we are going to classify this psoriasis under category 1 type of Koebner's phenomenon. Koebner's phenomenon, it is also called as Koebner's isomorphic phenomenon, which is basically defined as appearance of morphologically similar type of lesions at the site of normal skin after we induce any trauma. Okay, so after there is a trauma, what will happen? These patients of psoriasis, they are going to develop similar type of psoriatic lesions in the lines of the trauma. So not only psoriasis, please remember, lichen planus and vitiligo also will show the appearance of the similar look, morphological similar appearing lesions. There are other categories also according to the Boyd and Elder, who classified this Koebner's phenomenon into 4 types. So the number 1 variety has psoriasis, lichen planus, vitiligo, and these are true Koebner's phenomenon. These are examples for true Koebner's phenomenon. Why? Because here the property which is leading to the appearance of new lesions is autoimmunity. Whereas if you look at the category examples in the category 2, all those examples, they are all viral infections, and these viral infections, they are going to show a property called auto-inoculation. So because of the auto-inoculation, there will be formation of the new lesions. Appearance of new lesions is because of auto-inoculation of the viral particles. So they are called as pseudo-Koebnerization, examples for pseudo-Koebnerization. And this is the picture how the Koebner's phenomenon is going to appear. So here you are able to see the lesion is linear, and wherever the patient has scratched to those areas, there is development of new lesions. So this is called as a Koebner's phenomenon, and it has 2 important characteristics. It follows all or none phenomenon. And if there is a Koebner's phenomenon positivity observed in the patients, it gives us a brief explanation that the patient is still having active disease, and the disease is very severe. Even after the patient, if the patient shows Koebner's phenomenon, then we should probably change our treatment modality, because the patient is not responding properly to the treatment. Yes, now please try to answer this particular question in the poll in the chat section, friends. So Ijaj, what do you think the answer is? We have already discussed this actually in the previous slides. Okay, Ijaj says it is GP, that is gutted psoriasis. Very good, you are absolutely right. So question is telling a 12-year-old boy presents with 3 days history of a red scaly widespread rash, that too in a specific raindrop pattern over the trunk. He is otherwise well till now. So other than a recent severe streptococcal sore throat. So sore throat history is mentioned. A child is having this raindrop type of lesions over the trunk. So this is a classical description of gutted psoriasis. So in the psoriasis, we have seen how the chronic plaque type of psoriasis will present clinically. So chronic plaque psoriasis, which is also called psoriasis vulgaris, will have erythematous scaly papules and plaques surmounted by mica-like silvery scales. Whereas this gutted psoriasis, it is going to have characteristic features where usually the children are the ones who are affected, and there will be a mention of history of a recent onset of sore throat. So a sore throat history will be given, and usually it is secondary to group A beta hemolytic streptococci. After 1 or 2-3 weeks, there will be formation of raindrop like erythematous scaly papules and plaques. So the clinical picture is going to be a formation of a raindrop pattern, that is there will be many lesions which are appearing over the trunk. So these are all seen over the trunk. Yes, Vikash Kumar, you are right, beta hemolytic streptococci, group A beta hemolytic streptococci, and after the infection there will be formation, appearance of all these raindrop like, that is a shower of lesions. Here you are able to see in the picture as if someone has showered all these lesions over this child. The lesions are present arranged over the trunk, and these are going to have the clinical characteristic of being erythematous, and they will also show scaling. But unlike the psoriasis vulgaris lesions, these gutted psoriasis lesions are very small. So that is the reason why they are compared to the raindrop pattern. And if you observe in the investigations and in the treatment also, gutted psoriasis has few characteristics. So how is it different is gutted psoriasis, we have already seen that if you try to do Koebner's if you try to do the Auspitz sign will be negative in gutted psoriasis. So this is one small difference. And also here in gutted psoriasis, in the investigations we can do ASLO titers, anti-streptolysin O titers can be done, and also to confirm the diagnosis we can do a throat swab. A throat swab can be done, which can act as a corroborative evidence that there was in fact previous history of infection with group A beta hemolytic streptococci. And also one more important difference is the treatment part of gutted psoriasis consists of usage of antibiotics. Why? Because this is due to infection, so antibiotics like erythromycin and amoxicillin have a role in this gutted psoriasis. Okay, not only just gutted psoriasis, there are other conditions where raindrop type of lesions can be seen. So these conditions are seborrheic keratosis and chronic arsenic poisoning. So in these two also we can see gutted type of lesions. So now please try to answer this question in the chat section, friends, Ijaj and Vikas. So this was in fact asked many number of times by the AIIMS. So in the AIIMS this question is a very hot favorite. So I hope even you have read this question earlier. Okay, Ijaz says answer is B. Okay. So any more answers, Dr. Vikash? What do you think that the answer is? Okay, we'll try to find out what is the answer. So please read the question carefully, which is mentioning psoriatic patient showed a good response to oral steroids, but on stopping these drugs, that is stopping the steroids, there is a development of pustular lesions all over the body. So pustular lesions developed after the patient has stopped using these steroids. So and also the image is given where you are able to see multiple pustules over an erythematous base. So this is the clinical picture which is visible here. So we need to find out what is the diagnosis. So this description, whenever it is given, it is a classical description for the case of pustular psoriasis. So please remember, answer here is pustular psoriasis, but not acute generalized exanthematous pustulosis. So this acute generalized exanthematous pustulosis, the lesions here will not be seen in a patient of psoriasis. So this clue which is given in the question, psoriatic patient, is not in favor of acute generalized exanthematous pustulosis. In AGEP, the lesions are going to be present initially in the flexures. So same pustules will be there. Of course, as the name suggests, the pustules will develop in the flexures, and also the history that psoriatic patient took the steroids is not needed, and it's not in favor of acute generalized exanthematous pustulosis. So this is not the answer here, and few students I have seen, they thought why not it is a case of Staphylococcus aureus infection, because the patient took steroids. So there can be secondary bacterial infection, so why not it is Staph aureus infection. So please remember, the question is mentioning that the patient took steroids, and after stopping these drugs there is development of this pustular lesions. So if the question said that the patient while was on steroids developed pustular lesions, then we can think of a superadded infection, a bacterial infection with Staph aureus. But here as the question says that after stopping the drugs, that is after this immunosuppressive drug steroids are stopped, the lesions are developing, and so this is not a case of Staphylococcus aureus infection or any other bacterial infection. So few points about pustular psoriasis. So unlike chronic plaque psoriasis, here we are going to see lakes or sheets of pus. Okay, instead of erythematous scaly plaques, we will see lakes or sheets of pus, and if it is present in localized fashion, we call it as localized pustular psoriasis, and if it is present in generalized fashion, it is given the name called von Zumbu's disease. And if this pustular psoriasis, which is in generalized form, occurs in the pregnant woman, then we gave it a specific name called impetigo herpetiformis. Okay, and this is how the lesions are going to look clinically. So there are multiple tiny pustules, and if you try to take a culture and sensitivity or a gram stain from this pus, the result, the reports will be these are absolutely sterile without any bacterial growth. Okay, so these are absolutely sterile. And in psoriasis vulgaris, I want all of you to just remember this very important point: systemic steroids should never be used in psoriasis patients. Okay, so they are never used in patients of psoriasis. Why? Because if you stop these drugs, the patient will land up into ED, which is exfoliative dermatitis, or also called as erythroderma. and also patient can develop pustular psoriasis. So this is the reason why we should not start the patients on steroids, and there are some exceptions for this particular rule, so which are in pregnant women. So in pregnant women we cannot give all the medications, okay, because the medicines which are drugs of choices for the conditions of psoriasis and pustular psoriasis, they are category X drugs. Like for example, methotrexate and acitretin are the drugs of choices in chronic plaque psoriasis and pustular psoriasis respectively, but these are category X drugs and they are avoided in pregnant women. So that is the reason why we prefer using systemic steroids in pregnant women till the time of the delivery, and after that we can shift the patient to another medications. So this is for those who have no idea. So this is NEET PG 2022. The comprehensive course is going on. It started on November 1st and it is going to end on December 20th, and this is going to target the NEET PG 2022. So in case if you are targeting the NEET PG 2022, you can attend these classes with the help of taking subscription on Unacademy, and this is exclusively for Plus subscribers, and this on 29th this session is going to be there on vesiculobullous disorders. So now please try to answer this question in the poll, friends. So lady presents with buccal reticulate white streaks, pain increases on spicy food intake, patient gives no history of any tobacco usage, but examination reveals amalgam on the teeth. So what is your diagnosis? So Vikash, Ijaj, try to look at the picture and understand what are the clues which are given in the question. Okay, these type of questions are very much expected in this NEET PG 2021 and also in the future INS CET exams if next exam is not going to be realized. So Ijaz says it is lichen planus. Okay, everyone agrees with the answer. Please type your answers. I want everyone to attempt. So it does not matter if you make a mistakes, just attempt the questions, after which we will get to know what are our weaknesses and what are our strengths. So I think all of you agree with the answer given by the Ijaj, and yes, the answer here is lichen planus. Okay, sorry, it is lichen planus. You are all right. And few points about this lichen planus we will see. So till now in the psoriasis we have seen that skin involvement was there in psoriasis. So there are few important differences in between psoriasis and lichen planus. Okay, so in the case of psoriasis we can see few differences when compared to the lichen planus. So in psoriasis mucosa is not involved, whereas in lichen planus mucosa is involved, and the sites, if you see the sites in psoriasis, the most important sites are extensors, whereas in the case of lichen planus the sites are of involvement where the lesions are classically seen, they are all flexures. Okay, so these are very important differences in between psoriasis and lichen planus. Of course, apart from this there is one more difference, that itching, which is a predominant symptom in lichen planus, is absent in psoriasis. So these are very important differences I have given in that small table on the left side. So as I have already told you, skin, nails and mucosa, even mucosa are involved in lichen planus, and also there will be hair involvement also in lichen planus. It is just like psoriasis, it is also a chronic inflammatory disease where autoimmunity plays a very important role, and there are some triggers, like for example certain drugs like antimalarials and infections like hepatitis C virus and hepatitis B virus. These are the important triggers, and also mercury, which is present in the amalgam, is also important trigger in lichen planus, and the lesions are going to be present mainly over the flexure. So here you can see they are present over the wrist. They are present over the wrist, and this is the explanation for the question which I have asked. So the dental amalgam in the teeth here is acting as a trigger. So this amalgam has mercury in it, which is going to produce these reticulate white streaks. These are called Wickham striae. These are called as Wickham striae. That is the diagnosis here is lichen planus. So please remember, few students I have seen that they asked why not it is leukoplakia. It is not leukoplakia because in the question it will be mentioned that the patient has a history of usage of ill-fitted denture, and also there will be a history that there is a whitish membrane which is present, which is unscrapable. So these two are very important clues for you to diagnose it as a leukoplakia case. Since these two are not given in this question, the answer here is going to be lichen planus. So there are some very important characteristics of lichen planus which are usually remembered with the help of this mnemonic. You can say with this small trick called 5 P's, but not only 5, I have included 3 extra P's with the help of which you can remember all the important characteristics of lichen planus. So the lesion, the name itself suggests that these lesions are going to be plain, that is flat top, and there is clinically a very important symptom, that is pruritus, and there are going to be papules, there are going to be plaques which can be seen, and the lesions are going to have a shape which is polygonal, and there is also one more important nail change called pup tent sign, and also there is going to be a very important nail change called as pterygium. Okay, so this also is very important. And also another P here, these lesions of lichen planus, they will heal leaving a pigmentation, hyperpigmentation. So this P stands for pigmentation. So all these P's are very important in the case of lichen planus. And here also we will see true Koebner's phenomenon. So in lichen planus also we will see true Koebner's phenomenon, and unlike what we expect, so these lesions which are extremely itchy, but they do not induce scratching, but instead the patient prefers to rub these lesions instead of scratching. So there will not be any presence of excoriation. So excoriations will be absent in the patients of lichen planus. So now please try to answer this particular question in the poll, friends, in the chat section. So Dr. Ijaj, Dr. Vikas, what do you think the answer here is? Okay, Ijaj thinks it is the option D. Okay, very good. Actually, seborrheic dermatitis. Okay, so I will tell you what is the answer here. First, we will look at the question very carefully. Child presents with erythematous follicular papules on the trunk. So this is one clue given, and there are areas of normal skin within the lesions. So there is some mention that areas of normal skin are also seen within these lesions, and there is a thickening of the palms and soles. So these three are the clues which are given, and you need to diagnose this case. So please remember, in seborrheic dermatitis also, yes, you can see follicular papules, no doubt. Follicular papules which are erythematous in nature are seen in seborrheic dermatitis, but the other clues which are given, that thickening of the palms and soles, it is not seen in seborrheic dermatitis, and areas of normal skin within the lesions, it is also not seen in seborrheic dermatitis. So this is not the answer here. So the answer here is pityriasis rubra pilaris. So I will explain what will be the clinical features of pityriasis rubra pilaris, after which you can easily understand what are the other clues given in the question and why is the answer PRP. So we'll in short call this pityriasis rubra pilaris as PRP, where pityriasis stands for scaling, rubra stands for the lesions which are going to be erythematous in nature, and pilaris is a term used because we will see follicular oriented papules. So this is the justification for this name, pityriasis rubra pilaris, and even this is an example for papulosquamous disorder. That is why I have kept this question. So clinically you are able to see these erythematous follicle oriented papules which are present over the knee here, and yes, these lesions are appearing something very sharp. If you touch them, they are going to be very much pointed, and you will just feel that you are touching a nutmeg grater. So these are the nutmegs. So here on the extreme right hand side, so I think you are not able to see these nutmegs because I am there in the pathway. So this is the grater, which is used to grate these nutmegs. Okay, that is if you touch this, how do you feel? The same feel will be there if you touch these lesions of pityriasis rubra pilaris. So that is why it is called nutmeg grater like papules. So that is one characteristic of pityriasis rubra pilaris. And one more feature is that the lesions, these lesions which are erythematous follicle oriented papules, they initially start from the face and also from the neck, and they will slowly involve the rest of the body from above downwards. So this is called as cephalocaudal type of spread, and these spreading lesions, when they involve more than 90% body surface area, then we are going to see that the patient has landed into exfoliative dermatitis, that is erythroderma. Okay, and also there can be islands of sparing seen in these lesions. So I will show you the picture, after which you can understand what I am telling here. So these sites you are able to see all which are erythematous, that is the almost entire chest, also the upper parts of the arms, lateral parts of the arms, and also upper parts of the abdomen. All of these are having erythematous follicle oriented papules, but these areas, the axillary part is spared and it is appearing absolutely white, and these are called as islands of sparing, and these islands of sparing are very characteristic of pityriasis rubra pilaris. Okay, it is very characteristic of pityriasis rubra pilaris. And one more thing which was mentioned in the question is thickening of palms and soles. Which means keratoderma. So what does keratoderma mean? Kerato means thickening, that is hyperkeratinization, derma means skin. So in the palms and soles there is going to be a thickening of the skin which can be seen, and in pityriasis rubra pilaris it is specifically called as PRP sandals. So sandals means it is a footwear, so usually monks do wear it. So just like how that will be very rigid and tough, so similar texture will be of the foot of these individuals who have pityriasis rubra pilaris. So if you try to pinch the skin of the feet, then what you will get, you cannot pinch the skin and it is extremely thick, and it is characteristically seen in the case of pityriasis rubra pilaris. Okay, so that is the reason if you see the question again carefully, it is mentioning erythematous follicular papules on the trunk, and there are areas of normal skin within the lesion. So it is mentioning about the islands of normal skin, and there is thickening of the palms and soles. So all of these are pointing to the diagnosis of pityriasis rubra pilaris. So that's it in this session, friends. So if you wish to take this iconic subscription, and if you are having any doubts, you can reach me out on Telegram. So you can take, if your target is NEET PG 2022, then you have ample amount of time and you can take this 12-month subscription, and you can use this code D or MST. And if you wish to just see how this Unacademy works, so you can download this Unacademy learning app and check out all the special classes and how you can download the PDFs, and also you can revise those PDFs. So this is the name of the app, Unacademy learning app, which is available on Google Play Store and also on Apple. So you can download this and attend all the special classes which are absolutely free for everyone. And next class topic, Dr. Ijaz, I will put it up in this comment section of this class itself. So I think I will make a video on the questions of dermatology which were asked in this INI CET. Okay, that would be the next session. Or if at all there will be a clinical session, then I would make it a vesiculobullous disorder clinical session. Okay. So thank you so much, Dr. Ijaz, Dr. Vikas, whoever has attempted these questions in the chat section. And you can just download this and check out how the videos are, and you can ask your seniors who excelled in the various exams in the last this year, in this academic year, and you can take the feedback from your seniors also. And yes, if you are not yet following me on Unacademy, you can follow me to get all the latest updates of the videos which I upload. So that's it, guys. Thank you so much for all your patient listening, and bye bye. And please follow SMS, that is sanitization, mask and social distancing. And as usual, always, happy learning. Bye bye.